Hello everybody. So this is going to be a talk on platelet disorders and dysfunctions. So the disorders that I want to talk about are von Willebrand's disease, Glanzmann Thrombasthenia, Bernard-Soulier Syndrome, and Idiopathic Thrombocytic Purpura, or ITP. So first, in order to understand the disorders of platelets, we have to understand the normal function of platelets. So what happens why do we have platelets? Well, we have platelets to form clots. When do we need to form clots? Normally we form clots when there's an injury to the endothelial lining of a vessel. So you cut yourself, for instance. The initial event that needs to happen is you need to recruit that first platelet. So when you have injury to your endothelial lining, there is exposure of a protein, and that protein is called von Willebrand's factor. Now you have von Willebrand's factor that is expressed on your subendothelial lining. You also have von Willebrand's factor that's in your serum. They exist in both places. Essentially, they can do the same things. But when you're injured, you expose von Willebrand's factor on your subendothelial lining. Von Willebrand's factor attaches to glycoprotein 1b, and glycoprotein 1b is a protein that's expressed on the platelet, the outside of the platelet. So GP1b and von Willebrand's factor attach, and that's how you get your initial adhesion of a platelet to the lining. Now that platelet, once it adheres, releases factors, and those factors will recruit more platelets, and the platelets will then aggregate. So when platelets are aggregating together, all that means is the platelets are sticking together for one reason or another. And the primary aggregation for platelets is between glycoprotein 2b3a, which is another protein that's expressed on the outside of the platelet, and fibrinogen, which is a protein. And so GP2B3A and fibrinogen bind together, and that holds this complex of platelets together. And these two steps together is your primary platelet formation. This is primary hemostasis, and this is how you form your initial plug. With secondary hemostasis, after the coagulation cascade, the factor cascade, then what happens is this fibrinogen mesh, this complex of fibrinogen and GP2B3A will stabilize. And it stabilizes by factor 13A. And what factor 13A does is it cleaves fibrinogen into fibrin, which is much more stable. And so it's actually the factor cascade that stabilizes the clot. So you don't need factor to form an initial clot, but you do need factor to form a stabilized clot. And that's going to become important because with any kind of platelet issue, either qualitative or quantitative, if you don't have enough platelets or if your platelets aren't working correctly, you can't form that initial clot. And the problem with that is that it's going to cause an increased bleeding time. If you have a factor deficiency, you can form an initial clot, but the problem is going to be stabilizing those clots. And so your bleeding time in most factor disorders are going to be normal, but your PT and PTT are going to be increased, and that has to do with the factors, and we'll talk about that in a different section. So the symptoms of platelet-type bleeding are primarily superficial. The most dramatic are going to be what you see on the skin. So petechiae, purpura, and ecchymosis. Petechiae are just less than 3 millimeters in diameter. Purpura are between 3 millimeters and 1 centimeter in diameter, and ecchymosis are greater than 1 centimeter, and they're just, they look like little bruises. Menorrhagia is another common type of platelet-type bleeding. It's superficial. This is something that's very common because most women bleed every month, and so it's going to be difficult for them if they have any kind of platelet disorder. It's going to be difficult for them to form that clot, and they're going to have menorrhagia with their menstrual cycle. Gingival bleeding with dental procedures, with brushing teeth, with flossing. That's pretty common just because that area is manipulated a lot. Epistaxis, bruising, hematuria, occult GI bleeds, and so forth. So this is just a look at what those petechiae and purpura look like. And here we have an ecchymosis, and it's just based on the diameter. So it's really just the same thing going on. You've got bleeding into the skin. Okay, so first we're going to talk about von Willebrand's disease. So von Willebrand's disease is the most common platelet disorder. It's autosomal dominant, and what it is a deficiency of von Willebrand's factor. Remember, von Willebrand's factor present both in your serum and your subendothelial lining, and it's responsible for that initial stopping of the platelets. So you have to have your platelets have to adhere first to your subendothelial lining. And it's von Willebrand's factor that attaches to the GP1B on the platelets. So if you don't have von Willebrand's factor, it's going to be very difficult to have that adhesion. Most patients, they're deficient, not completely absent in von Willebrand's factor. So they do get some clot formation, just not sufficient. So when you have von Willebrand's disease, you don't have enough von Willebrand's factor, and so your bleeding time is going to be increased. Why is it bleeding time increased? Well, that's because you can't form the initial clot. So it's going to take longer for the clot to form because you have deficiency in von Willebrand's factor. And again, the symptoms are going to be symptoms characteristic of superficial platelet-type bleeding. So menorrhagia, epistaxis, bruising, gingival bleeding, petechiae, and so forth. And von Willebrand's disease coincides with a minor factor VIII deficiency. So you do have a slight factor deficiency, but it's generally not clinically significant. A lot of times, von Willebrand's disease will be expressed when the patient takes aspirin or an NSAID. So that's something to keep in mind. If it could be a patient that has just been prescribed a baby aspirin for one reason or another, and now they've developed bleeding. As far as labs, this is going to be important to know. Anytime you've got a bleeding disorder, there's 4 things you need to get. You need to get a bleeding time. And that bleeding time is primarily telling you that whether or not you have a platelet disorder. With platelet disorders, you're always going to have elevated bleeding time. PT and PTT are going to reflect if you have a factor disorder. So PT is your extrinsic pathway, and PTT is your intrinsic pathway, and we'll talk about that in a different section. In von Willebrand's disease, you can have an elevated PTT because you have that minor factor VIII deficiency, but for the most part, PTT is normal in von Willebrand's disease. The platelet count is going to be normal, so you need to get a platelet count because that's going to tell you if you have a quantitative defect in platelets. So sometimes you might have platelet-type bleeding because you don't have enough platelets. That's not the problem in von Willebrand's disease. In von Willebrand's disease, you don't have enough von Willebrand's factor. You've got enough platelets. They can work fine if they need to, but you don't have the von Willebrand's factor to attach to the platelets. And so it's really a qualitative defect of the platelets. The platelets can't work rather than not having enough platelets. So anytime you have platelet-type bleeding, you should get a Ristocetin platelet test. And what the Ristocetin platelet test is it's a way that we can tell what kind of qualitative defect the platelets have. So if your platelets are low, you don't need to get a Ristocetin platelet test because you know that you've got a disorder of low platelets and that's causing your platelet-type bleeding. But if you have a normal level of platelets and an elevated bleeding time, that's telling you you have a qualitative defect of platelets, and so you want to know what kind of qualitative defect that is. And the Ristocetin platelet test will tell you that. So with your Ristocetin platelet test, what you're doing is you're inducing in vitro aggregation of platelets. So remember, you have normal von Willebrand's factor that occurs normally in your serum, assuming you're normal, and you have GP1B that is expressed on the platelets. What Ristocetin does is it induces the attachment of GP1B and von Willebrand's factor. So in a normal person who has normal von Willebrand's factor and normal GP1B, adding Ristocetin is going to cause this platelet aggregation between von Willebrand's factor and GP1B. In patients who don't have enough von Willebrand's factor or they have deficient GP1B, which we'll talk about in the next disease, The Ristocetin, when it's added, is not going to cause aggregation because you don't have enough of one or the other to aggregate the platelets together. You need to have both. So when you have von Willebrand's disease, you're going to have abnormal aggregation. You're not going to get that normal aggregation you see in a normal patient. However, when you add normal serum, that normal serum has von Willebrand's factor. It doesn't have GP1B because remember, GP1B is expressed on the platelets. It's not in the serum. When you add normal serum, which has von Willebrand's factor, it's going to normalize and you're going to get normal aggregation because you're adding serum with von Willebrand's factor. And that's how you're going to be able to tell that the platelet or that the patient has von Willebrand's disease, is that adding normal serum to that abnormal Ristocetin test corrects the abnormality. Okay, so how do we treat von Willebrand's disease? It's primarily supportive. We give them iron replacement as needed. So if they are anemic, then we do replace them with iron. A lot of times we're going to have to do that because they lose blood. If they have significant bleeding, mild bleeding, a lot of times this will be women who are in their period or in patients that are going into surgery, then the best thing to give them medically is DDAVP, which is desmopressin. And of course, avoid aspirin and NSAIDs. And the second line therapy is going to be direct factor VIII replacement, where you're replacing the factor that's often deficient in von Willebrand's patients. Okay, the next disease we're going to talk about is Bernard-Soulier Syndrome. So Bernard-Soulier Syndrome is very similar to von Willebrand's disease, except for the fact that this is more rare, it's an autosomal recessive condition, and it's a disease that's caused from an abnormal GP1B expression on the platelets. So remember, von Willebrand's disease was a low amount of von Willebrand factor. This is a low amount of GP1B expressed on the platelet. So remember, both of those are needed for that attachment, for that initial adhesion, but this is a different disease because it's not von Willebrand's factor that's the problem, it's the GP1B. So it looks the exact same as von Willebrand's disease because it's essentially the same pathophysiology. You don't get that initial adhesion, and so you're going to have these platelet types symptoms. So menorrhagia, epistaxis, bruising, petechiae, etc. These patients will present the exact same way as von Willebrand's disease. So you can have, in labs, you'll have an elevated bleeding time. Your PT and your PTT will tend to be pretty normal because it's not a factor problem. However, sometimes in Bernard-Soulier syndrome, you get a low platelet count. And it's not going to be significantly low, but it can be low normal or a little low. And that's really not known why it happens, but you can get a mild thrombocytopenia with Bernard-Soulier syndrome. We don't know why it happens. And sometimes, just like von Willebrand's disease, your CBC will show an iron deficiency anemia. So for the most part, the labs are similar to von Willebrand's disease in that your bleeding time is elevated and everything else is normal. But just remember, sometimes in Bernard-Soulier syndrome, you may have a low platelet count. If it is low, it's not going to be significantly low. So again, the best diagnostic test here, because you have an elevated bleeding time, you're going to want to get a Ristocetin platelet test. And just like von Willebrand's disease, the platelet aggregation is going to be abnormal because you don't have your GP1B. And so in von Willebrand's disease, the problem, of course, was that you don't have von Willebrand's factor, and so you don't get aggregation when you add Ristocetin. With Bernard-Soulier syndrome, you don't have enough of the GP1B, which is the little blue thing I've got here. But you do have normal von Willebrand's factor. Now, when you add normal serum to this abnormal result, you're not going to get a normalization because the problem is GP1B. It's not von Willebrand's factor. So all you're doing when you add normal serum is just adding more von Willebrand's factor, but that's not the problem. You have enough von Willebrand's factor, and so it's not going to normalize. So a Ristocetin platelet test that's abnormal, that doesn't normalize with normal serum, is going to be Bernard-Soulier syndrome. So the treatment for Bernard-Soulier syndrome is supportive, and DDAVP is not useful for Bernard-Soulier syndrome because remember what DDAVP does is it increases the expression of factor VIII and von Willebrand's factor. Again, you're going to avoid antiplatelets like aspirin and NSAIDs, and if it's absolutely necessary, you can use transfusion of platelets. Okay, Glanzmann's thrombasthenia. So up until now, we've been talking about diseases of the initial step in clot formation, so the adhesion. Now we're talking about the second step in clot formation. So this is GP2B3A attaching to fibrinogen. So Glanzmann's thrombasthenia is a rare autosomal recessive condition where you have abnormal GP2B3A expression on the platelets. So just like Bernard-Soulier syndrome, it's a disorder of that glycoprotein, but in this case, it's a disorder of the glycoprotein 2B3A. And that's needed to attach to fibrinogen to form your larger clot, to attach to other platelets. So GP2B3A is responsible for binding fibrinogen to form this initial primary clot. And of course, it's also needed to form the mature clot, which occurs after you get factor 13A and you can lyse fibrinogen into fibrin and form that stable clot. So the symptoms, again, here are going to be platelet-type bleeding because you have difficulty forming that initial plug. So menorrhagia, epistaxis, bruising, petechiae, etc. Same symptoms as we've had with the other diseases. As far as the labs here, you're going to get an elevated bleeding time as you get in all of your platelet-type bleedings. You're going to have normal PT and PTT, and your platelet count is going to be normal. So again, this is a qualitative defect of the platelet. It's not a quantitative defect. So your platelet count is normal, it's just your platelet behavior is not normal. So the diagnosis here, it's going to, again, be a Ristocetin platelet test. The difference here with the Ristocetin platelet test is that you are going to have a normal result. Why? Because look at what's happening here. With the Ristocetin platelet test, we're talking about the binding of von Willebrand factor and GP1B. In von Willebrand factor and GP1B, that's only diseased with the von Willebrand's factor disease and Bernard-Soulier syndrome. With Glanzmann's thrombasthenia, it's a disease of GP3B2A. So you do not have disease of von Willebrand's factor and GP1B, so that's all normal. So everything's going to be normal with this Ristocetin platelet test. So you're going to have a normal Ristocetin platelet test, but you need to do the Ristocetin platelet test to exclude von Willebrand's disease and Bernard-Soulier syndrome. So because you have a normal Ristocetin platelet test and you have platelet-type bleeding and you've got a normal platelet count, all of that points to Glanzmann's thrombasthenia. And it's rare, but because you have a normal platelet count, that excludes a quantitative platelet defect, and because you have a normal Ristocetin platelet test, that excludes a defect of von Willebrand's factor and a defect of GP1B. So that leaves Glanzmann's thrombasthenia. And if you were to run factor levels, they would be normal, because this is simply a disorder of GP2B3A. How do we treat this? It's the same as treating Bernard-Soulier syndrome. You can't use DDAVP because the problem's not von Willebrand's factor or factor VIII, so it's just supportive. Again, avoid NSAIDs and aspirin and transfuse platelets if absolutely necessary. So when do we transfuse? Well, usually it's going to be important when you're talking about surgery. So if you're going to do any kind of surgery, definitely if it's below 50,000. And if it's neurosurgery, you're going to want to be a little more careful, so usually about 100,000. Anytime the patient gets below 10,000, you're going to transfuse them. Okay, so ITP. So ITP, unlike the other diseases we've been talking about, this is a disorder of, a quantitative disorder of the platelets. So up until now, we've been talking about platelets being disordered themselves, a qualitative defect of the platelets. Now, this ITP is a quantitative defect of the platelets. You have thrombocytopenia. You have low platelets. And ITP is a specific kind of thrombocytopenia that is idiopathic, but it's associated with certain things. So it can be associated with autoimmune diseases, it can be associated with HIV, lymphoma, post-viral infection, and various drugs. But it is an idiopathic thrombocytic purpura. It's idiopathic in that it's definitely not caused by leukemia. It's not caused by any kind of bone marrow disorder, bone marrow infiltration, and so forth. So symptoms here are going to be, again, the same. This is platelet-type bleeding. With platelet-type bleeding, it doesn't matter whether it's qualitative or quantitative. The problem is with the platelets, either qualitatively or quantitatively. And so you're going to have menorrhagia, purpura, gingival bleeding, ecchymoses, so forth. It's going to be very important on physical exam to exclude splenomegaly, because if you have an enlarged spleen, that can sequester your platelets, and that can also cause thrombocytopenia. So in ITP, you never have splenomegaly. As far as labs, the hallmark is going to be an isolated thrombocytopenia. So yes, of course, you do have an increased bleeding time because you have a problem with your platelets. But in this case, with ITP, you have a very low platelet count because the platelets are being eaten up by macrophages. So this is a defect quantitatively of the platelets. The CMP is going to be normal, and you should definitely ensure that the peripheral smear is normal, and I'll tell you why in a little bit. So if thrombocytopenia is accompanied by anemia or leukopenia, then you're kind of getting suspicious of possibly a leukemia, because you've got a pancytopenia rather than just an isolated thrombocytopenia. So in those cases, you may want to get a bone marrow biopsy to exclude any of the myelodysplastic syndromes like leukemia. And particularly, you're going to do this in patients older than 60 because CLL and CML and lymphomas are so common. As far as the treatment for ITP, if the patient is stable, we're going to give them prednisone. That's going to help with this autoimmune process. Second-line therapy is going to be reserved for patients who have precipitous drops in their platelet count or who have life-threatening bleeding disorders. And what you would do for them is either IVIG or RhoGAM. Remember, you can only use RhoGAM in Rh-positive patients. So GI bleeds, CNS bleeds, anytime platelets go less than 10,000, you're going to give them IVIG or RhoGAM. What you're not going to do is never, ever, ever, ever give a patient with ITP platelet transfusion. Because remember, what's the problem with ITP? Your platelets are being eaten up. So there's absolutely no point in giving platelets to somebody whose disease is that their platelets are being eaten up by macrophages. So no platelets for patients with ITP. You're going to give them prednisone. If that's not enough, then you give them IVIG or RhoGAM, particularly if it goes less than 10,000 or if they have any major complications from their ITP. Some other causes of thrombocytopenia, there are a lot, so don't get overwhelmed here, but we'll look at these at how they're unique from one another. So TTP, or thrombotic thrombocytopenic purpura, is going to manifest as widespread clots, also renal malfunction, and then this is important, sheared red blood cells on smear. And what this is from is the fact that you have all of these clots, and the red blood cells that aren't clotted try to get through these clots, and the clots just wind up shearing off part of the red blood cell. So make sure that whenever you have a patient with these widespread clots or something abnormal like that, that you get a smear. Anytime you have hematologic abnormality and you're getting a CBC, make sure you get a smear too, because the morphology of any of these cells can give you a hint as to what's behind this, and in this case it would be thrombocytopenia. This TTP is associated with a deficiency of an enzyme called ADAMTS13. And what that enzyme is responsible for doing is helping to break up clots. So if you have a deficiency of that, then the balance is going to be shifted towards developing clots. HIT or heparin-induced thrombocytopenia, look for a recent history of commencement of heparin. And what happens then is, hopefully these patients are in the hospital already when they develop this, but what's going to happen, you get your CBC every day, you look at the platelets and they're dropping. And so as these platelets drop, you look for heparin-induced thrombocytopenia. Usually there's also widespread thrombosis, and most of the time, if this manifests clinically, it'll be DVT or pulmonary embolism, so look for that. Drug-induced thrombocytopenia is a mild form of ITP. It looks just like ITP, but it's going to coincide with commencement of various drugs. So look for any drugs that have been started recently. There are drugs that are associated with drug-induced thrombocytopenia more than others. One particular one is quinine, however, we don't use that very often here. Myelodysplastic syndromes of leukemia are associated with thrombocytopenia. What you're also going to look for here is also an anemia and a leukocytosis or a leukopenia. So this particularly happens with leukemia, and so with leukemia, usually you see this sort of classic triad where all your blood cells are disturbed. So your red blood cells are disturbed, that's going to be an anemia. Your white blood cells are disturbed, usually that's going to be a leukopenia, however it can be a leukocytosis, and then thrombocytopenia. So all three are going to be low, and you see this a lot in AML or AL and little kids who come in either sick with something and all their blood cells are low, or perhaps they have bony pain, or they're pale or something like that. HELP syndrome is an obstetrical disorder, so these patients will be pregnant. Usually they have a history of preeclampsia or at least symptoms of preeclampsia, so swelling, high blood pressure, and HELP syndrome, you see high liver enzymes, and then this thrombocytopenia. Disseminated intravascular coagulation, usually these patients have an infection, and that causes the DIC. However, they can also get this if they're pregnant, or if they have AML, the M3 version of AML. And this is always going to include very abnormal bleeding results. So if you get your factor, coagulation, bleeding time, it's all going to be abnormal. So they're going to have low platelets because you're getting disseminated coagulation, so those platelets are all sticking together. You're also going to have an abnormally elevated PT and PTT because you're exhausting your factor. Hemolytic uremic syndrome, this usually happens in association with infection from E. coli 0157H7, and this will manifest as jaundice because of the hemolytic anemia, the hemolysis, and then you can also, will get with this an elevated indirect and total bilirubin. You can also get uremia, thromboses because of the clots. So just to recap, with your bleeding studies, von Willebrand's disease is an elevated bleeding time. Well, all of these are elevated bleeding time because they're all platelet disorders, either qualitative or quantitative. With von Willebrand's disease, sometimes you can have an elevated PTT because you may have a coinciding factor VIII disorder, but for the most part, it's just going to be elevated bleeding time. With Bernard-Soulier syndrome, you're going to have an elevated bleeding time, possibly with low platelet count, and the reason for that is unknown. With Glanzmann's Thrombasthenia, this is a disease of GP2B3A, and this is going to be just an isolated elevated bleeding time. And then with ITP, you've got an elevated bleeding time and low platelets because your macrophages are eating up your platelets due to some kind of immune issue. Remember, platelet-type bleeding symptoms are the superficial symptoms: menorrhagia, epistaxis, purpura, gingival bleeding, bruising, hematuria, occult blood and stool. It's not hemarthrosis or hemorrhages in the muscles. Not deep bleeding, it's superficial bleeding. Best diagnostic test after basic lab work is the Ristocetin platelet test. That's going to help you determine what kind of qualitative platelet disease you have. If you have abnormal aggregation, then you know you have a problem with adhesion, and what you're going to do is the Ristocetin, you're going to add normal serum, And if it corrects, then you know you have von Willebrand's disease, because the normal serum is just adding von Willebrand's factor. So if adding the normal serum corrects it, then you know that it's the von Willebrand's factor that's deficient. If it doesn't correct with the added normal serum, then you've got Bernard-Soulier syndrome. If you have normal aggregation with your Ristocetin platelet test, assuming you have a normal platelet count, then you've got Glanzmann's Thrombasthenia. And of course, ITP, you're going to know right out the gate that because it's going to be a very, very, very low platelet count, in addition to your elevated bleeding time and normal PT and PTT. And that's it.